Hello and welcome to an introduction to Read Codes for General Practice. This presentation is provided by Terminology Services, part of Public Health Scotland. The aim is to provide an overview of Read Codes to assist when selecting codes. Please be aware there are no national standards in Scotland in relation to read coding. Each practice must have their own read coding protocol in place. During this session, we will discuss a background to medical coding, including what clinical coding is and how read coding relates to other coding systems used in Scotland. A brief history of read codes, the hierarchical structure of read and how this can assist in code selection, common abbreviations and their meaning, and tips on searching for and selecting read codes. So what is clinical coding? Clinical coding is the translation of medical terminology as it is written by a clinician into a coded format, usually an alphanumeric code which is either nationally or internationally recognised. Clinicians may use different names for the same condition. For example, a myocardial infarction may also be called a heart attack. Using free text, i.e. just typing in the condition, can make it difficult to identify all patients with a certain condition, as there could be differences in spelling, typos or other formatting differences. By applying a clinical code, such as a read code, both diagnostic descriptions are assigned the same alphanumeric code. Clinical coders translate clinical notes and records into this coded format. In primary care, coding responsibilities may be shared amongst a variety of staff, including administrators and clinicians. Coded information, documentation processes, and communication among staff is vital to ensure high quality of recorded data. Coding can only ever be as good as this collaboration. We recommend that each GP practice has a lead clinician appointed to act as the first point of call for queries. This improves consistency within the practice. Whilst you may only be working with one type of coding, it is important to understand this is part of a larger family of coding systems used in the NHS. Clinical coding takes place in many different clinical settings. Depending on the setting and purpose, different coding systems are used. These can be split into classifications and terminologies. Classifications are used within secondary care hospitals. Coding is applied retrospectively at the end of an episode of care. Classifications categorise diagnoses or procedures according to certain criteria. Classifications have national standards to ensure they are applied consistently across Scotland. They are used for data analysis purposes and at a national and local level. Due to the nature of classifications, everything can be coded, but may not have its own unique code. ICD-10 is an international classification used for coding diagnoses, signs and symptoms in Scotland. OPCS4 is a national classification created and managed by NHS England with input from all UK nations. It is used for coding procedures and interventions in Scotland. Terminologies are a structured collection of descriptive terms used in clinical practice and can be delivered at the point of care as well as retrospectively after an episode of care has been delivered. They contain diagnoses, signs and symptoms, procedures and interventions, as well as administrative terms. Within a terminology, each term is given a unique code. Terminologies do not have national standards which can make analysis more complex. Read version 2 Scottish edition is the current terminology used in Scotland in primary care. However, it is deprecated and will eventually be phased out. Since 2016, it is no longer updated or maintained. This was previously done by NHS England. SNOMED CT is an international terminology which will take over from Read. This is a long-term program of work and will take several years to implement. It is a much larger terminology than Read, with many more healthcare concepts available. England already used SNOMED CT in general practice. If you wish to know more about SNOMED, please see the Terminology Services website shown in the last slide of this presentation for more information and helpful links. The Read Code clinical classification was originally devised in the early 1980s by Dr. James Read, a UK general medical practitioner. It was designed for use in primary healthcare and Dr. Read was awarded an OBE for his service to medicine. In 1988, Read became a standard in primary care in Scotland. In 1990, the Department of Health purchased Read and it became Crown copyright. It was maintained by the newly created National Health Service Centre for Coding and Classification in England. Read version 2 is the current version used within NHS Scotland, and updates to Read's codes ceased in April 2016, as owners NHS England moved across to using SNOMED CT. Where a clinical need is identified for a new Read term to be created, these are created as local codes by the supplier. These may vary by practice and/or by health board, and Public Health Scotland does not have easy access to these codes. NHS Scotland have started an approximately 10-year piece of work to move towards the use of SNOMED CT as a replacement for Read. So what are Read codes? Read is a coded thesaurus, i.e. a structured collection of clinical terms allowing clinicians to record patient records electronically. There are over 90,000 codes in Read version 2 used in Scotland. It is structured as a 5-digit alphanumeric code. Letters are case sensitive, i.e. upper and lower case, meaning searching using the wrong case will not result in the code being found. There are dots to make up the code to 5 digits, which also require inclusion when completing a search. Read version 3 is a newer version that was not greatly utilised, but was used by some GP IT systems within NHS England until they moved to SNOMED CT. Primary care in Scotland will not move to version 3 and will go directly to SNOMED CT. Read codes are arranged hierarchically, with the level of detail increasing as you move down the hierarchy. The hierarchical approach is intended to help users to find related terms and decide on an appropriate level of detail. If a code has another level beneath it in its hierarchy, it is known as the parent code, and the codes beneath it are its children. Read codes are split into 3 sections or chapters. The number or letter starting the code denotes the chapter. Chapters starting with a number are history, symptoms, procedures, and background information. For example, Chapter 1 is history and symptoms and includes codes for things like personal history or family history of a disease. Chapter 9 is the administration chapter and includes codes for things like a patient who did not attend an appointment. Chapters starting with a letter are diagnoses. They are divided into different body system diseases as seen on screen. Chapter R and Chapter Z are slightly different and will be explained in more detail later in the presentation. Read codes are arranged hierarchically. The level of detail increases as you go down the hierarchy. The hierarchical approach is intended to help users to find related terms and decide on an appropriate level of detail. If a code has another level beneath it in the hierarchy, it is known as a parent code, and the codes beneath it are its children. The children can also then be parents with more child codes beneath them. This can be seen here with the circulatory system diseases chapter. The top level parent code is G ... with the children underneath. Moving down the hierarchy, you can see that the codes and the code titles become more specific. At the bottom is acute anteroseptal myocardial infarction, G3011, which represents the most specific conditions seen here. Read has flexibility within the clinical terminology used. Different names may be used by clinicians when referring to the same condition or procedure. These are known as synonymous terms. Read has a preferred term for each code, shown as the code title, as well as any synonymous terms where applicable. This allows for synonymous terms to all be applied to the same Read code. For example, acute myocardial infarction is the preferred term for the code G30 ... It also has several synonymous terms included within Read, such as heart attack and coronary thrombosis. This means when searching any of these terms, the code G30 ... will be suggested. It also allows a simple check that is the correct code by simply checking the synonymous terms. Preferred terms will have 2 additional digits 00 at the end of the code, while synonymous terms will have the additional digits 11, 12, etc. at the end of the code. This means they can be differentiated from each other. Please be aware when using Read that some of the clinical terms are considered outdated. This is due to the age of the terminology. These terms were in clinical use in the 1980s when Read was created. As Read is deprecated, these terms cannot be changed. Reed's Planter's placement, SNOMED CT, is more clinically up to date and will continue to be updated as the clinical terminology changes. How are codes selected in Reed? The process may vary slightly between the different systems used, and this recording is based on the Reed browser available from NHS England Technology Reference Update Distribution Centre, or known as the TRUD. The process is similar to using an internet browser. Type in a term or part term and a list of possible options are presented. The more detail provided in the search, the more refined the search results will be. Searching AST will result in a longer list of possible matches than the full clinical term asthma. From here, select the most appropriate code from your local protocol and applying knowledge of the Reed hierarchy, such as chapter type. There are a range of medical abbreviations used within Reed. Some are very commonplace in medicine, such as C/O complaining of and O/E on examination. There are some which originate in classifications, such as NOS, OS, and NEC. These will be explained further later in this presentation. Take care with medical abbreviations, as some have more than one meaning. For example, DHS can mean diabetic hyperosmolar state or dynamic hip screw. Consider the specialty and context of the abbreviation when applying codes within Reed. There are abbreviations in Reed which are found in square brackets found at the beginning of terms. These each have a specific meaning. V in square brackets refers to supplementary factors influencing health status or contact with health services other than for disease or illness. These codes are a subtype of Chapter Z and specified conditions. All codes begin with ZV and terms begin with V in square brackets. For example, ZV700 V in square brackets, routine health checkup. X in square brackets refers to codes derived from ICD-10 codes when ICD-10 was first introduced. These codes were added at this time as they were deemed clinically useful. For example, H small case y small case u 0 dot X in square brackets, acute upper respiratory infections. D in square brackets refers to symptom codes that originate from ICD-10 codes and still carry a cross-reference. They enable a vague diagnosis to be recorded or a symptom or sign to be used as a working diagnosis. These should only be used when a precise diagnosis is unavailable. For example, R0021 D in square brackets, fainting. M in square brackets refers to morphology of neoplasms, which is a subchapter of Chapter B neoplasms. They describe the morphology or cell type of neoplasms as opposed to a site of where the neoplasm is located within the body. These codes can look very similar, so take care when selecting. For example, BB small case R01 M in square brackets, acute leukemia NOS is a morphology code, and B680 dot acute leukemia NOS is a site code. Some of the abbreviations within Reed were originally derived from classifications. They are selected in specific circumstances. Not otherwise specified, abbreviated to NOS, is commonly found in Reed, usually at the bottom of a hierarchy. This is equivalent to unspecified, and these codes should be applied when the code title is all the information provided within the clinical notes. Let's look at the example of otosclerosis currently shown on screen. Using all available information, the code furthest down the hierarchy should be selected. Where no further detail other than otosclerosis being provided, this could be coded to F57 small case z dot otosclerosis NOS. If the coder did have further information, it should be coded to the more specific appropriate code. For example, obliterative otosclerosis would be coded to F571 dot. Selecting F57 small case z dot otosclerosis NOS shows definitively that no further clinical information was provided as the coder has selected the NOS code. Selecting the top level code F57 ... autosclerosis could also potentially mean autosclerosis unspecified, and that no further clinical information was available. However, as the NOS code has not been selected, this cannot be confirmed. Please note, some practices do not use the NOS codes due to local protocol reasons. This is a decision taken by each practice. Another classification-derived abbreviation is not elsewhere classified, abbreviated to NEC. An NEC code should only be applied when the condition or procedure is not covered by another available code, but further clinical detail is available. Deciding that a particular condition or procedure is not covered by any other category requires knowledge of the structure and content in READ. NEC can be used as a flag to remind the coder to double-check there is not a more specific code elsewhere. Let's look at the example of viral pneumonia shown on screen. A clinical diagnosis of fictional virus pneumonia has been provided. It is not one of the viruses shown in H200. To H203. But a specific virus has been identified as a causative agent by the clinician. H20 small case z. Viral pneumonia NOS cannot be selected as there is additional information and a specific diagnosis. However, there is no code available in READ. Therefore, the correct code is H20 small case y. Viral pneumonia NEC, as it states not elsewhere classified, demonstrating more clinical information exists, but no code is available within READ. Often, a clinical statement can be coded in different ways within READ. For example, the term patient has a sore throat could be recorded in different ways depending on the detail given by the clinician. This includes a variety of different code types. Let's see what READ codes we could apply. There are various different options available from a range of chapters within READ. 5 are shown on the slide. A340. Streptococcal sore throat is from Chapter A, the Infections chapter. This code is for a specific bacterial infection causing a sore throat. You would need additional information of the streptococcal causative agent before this code could be selective. H02. Acute pharyngitis is from Chapter H, the Respiratory System Diseases chapter. Note, the sore throat NOS is a synonym for acute pharyngitis. R041. D in square brackets throat pain is from Chapter R, the Signs, Symptoms and Ill-Defined Conditions chapter. Codes 1C B3. Throat pain and 1C92. Has a sore throat are both from Chapter 1, the History and Symptoms chapter. This is an example of how important it is to be accurate and specific in clinical records. We've seen how a range of codes in different chapters are given in a search for sore throat. But how do you know which one to pick? We need to be accurate, specific, and appropriate. Always be as accurate as possible when searching for clinical terms. Ambiguity will cause difficulties in code selection. For example, the term dermoid cyst. You can see that to code this term, we need to know the anatomical site, as it can be coded in 3 different chapters dependent on this information. Also try to avoid ambiguous abbreviations, which can have different medical meanings, depending on the specialty. For example, MS could be multiple sclerosis or mitral stenosis. MI could mean mitral incompetence or myocardial infarction. Consider the context of the abbreviation and, in doubt, check with a responsible clinician. Please be aware that some abbreviations may not match the terms found in READ. Diseases can have many different coding options in READ. For example, if the only information is asthma, this may be coded to H33 small case z. Asthma unspecified NOS. However, where the information provided details intrinsic asthma, the more specific H331. Intrinsic asthma code may be applied. Consider which code is the most appropriate given the clinical context. For the terms wheeze and rash, there are different options available from different chapters. When is it appropriate to code this as observation, and when is it a symptom? Use the clinical context to decide and consult with your protocol or lead clinician if you're unsure. Let's work through an example to demonstrate. A doctor sees a patient who complains of rectal bleeding. If the patient had painless rectal bleeding per rectum with no obvious cause, this is coded to the symptom code of 196C. Painless rectal bleeding. Alternatively, if confirmed by the doctor to be a symptom of their hemorrhoids, this could be coded to G8480 bleeding hemorrhoids NOS. There is no need to code the symptom as it's part and parcel of the condition. Sometimes, even when searching for an exact term, it can be difficult to find the correct code and read. It can be helpful to try different ways to search to increase the quality of results. Think about alternative ways to describe a condition or procedure. You can try searching common abbreviations such as UTI, searching for lay terms such as athlete, using eponyms such as Down syndrome, concentrating on more unusual words, and trying to avoid common terms such as acute, which will result in a long list of possible options. Try different names on an anatomical site. For example, nasal instead of nose, renal instead of kidney, as these may provide different results. These are some tips to get you started. Think laterally and try a range of options when searching for codes. As mentioned earlier, you can try searching on part of a word. This can be helpful if you're unsure of spelling or to gain a larger list of possible options. However, be aware that you may lose specificity and it may result in being presented with irrelevant options. In summary, when coding in your practice, it is recommended that you work as a team, have a practice read coding protocol and ensure it is up to date. This will help with consistency of coding. Nominate a clinical lead for queries. This will further improve consistency within your practice. Create crib sheets for difficult areas. Have regular audits to ensure compliance with the practice protocol and consistency within coding. Train new staff members in READ and the application of codes, including watching this recording. Following these steps will help make coding easier and more accurate overall. Thank you for watching this presentation. We hope you found it useful. Should you have any questions or feedback regarding this topic, please contact our team using the details seen on screen. Thank you.